So welcome everybody. We are very excited to have you with us for this case of the Assembly of Pediatrics. We are they're going to be presenting the uncommon etiology of clubbing. There are two cases. This is the second case, but we're going to do it first. And for Gamze Akça Dinç from Ankara Bilkent City Hospital. So, Gamze, can you go ahead?
Okay. First of all, good evening. My name is Gamze Akça Dinç, and I'm a final year fellow in pediatric pulmonology at Ankara Bilkent City Hospital in Turkey. Today, I would like to share with you a case highlighting a rare cause of digital clubbing. A 5-year-old boy, the patient initially presented to an external facility with symptoms of acute gastroenteritis. On physical examination, digital clubbing was observed and oxygen saturation was measured at 88%. Consequently, the patient was referred to our institution with a preliminary diagnosis of congenital heart disease. Medical and family history were unremarkable. The patient's height and weight were within normal reference ranges. Auscultation revelated no abnormalities. Notable pathological findings included digital clubbing, a systolic murmur, and reduced oxygen saturation. Oxygen was administered via a non-respirator mask, resulting in oxygen saturation of 88% on room air and 98% with supplemental oxygen. The chest X-ray, an opacity was noted in the right lower lobe, consistent with a suspicious lobar pneumonia pattern. This is the laboratory findings were normal. And the echocardiography performed on the patient was normal. And differential diagnosis, lobar pneumonia, congenital cardiac disease, chronic lung disease, congenital pulmonary malformation, pulmonary arteriovenous malformation, chronic gastrointestinal disease, rheumatologic disease, hyperthyroidism. Due to unremarkable initial tests and ongoing oxygen need, a contrast-enhanced chest CT was performed. The right inferior pulmonary vein appears dilated, measuring 13 millimeters and is tortuous. A branch originating from the right pulmonary artery is connected to a peripheral lesion measuring 33 by 33 millimeters, composed of a vascular network at the distal end of the dilated pulmonary vein. The area is interrupted in favor of a pulmonary arteriovenous malformation. Compressive parenchyma is observed within the region associated with the lesion. And contrast echocardiography, agitated saline contrast echo right arm injection demonstrated microbubbles in the right heart chambers, followed by their appearance in the left chambers. The management, transcatheter embolization was performed. Oxygen saturation improved from 72% pre-procedure to 98% post-procedure. Do you have any questions? I think I was a little bit fast. Sorry.
So I have a question. So can you tell us something about his past medical history?
Can I answer?
Yeah. Oh.
He referred to our clinic to assess why they suspect about the lobar pneumonia, and his oxygen requirement will not will not respond to non-specific antibiotics. And then when we evaluate patients, he didn't have any pneumonia, any bronchitis, or any lower respiratory infections. They didn't know about anything. And then when we evaluate him, we recognize his clubbing. And then when we then start to evaluate him for the etiology of clubbing.
So the first time he
Yes,
came to you
yes.
guys was with a clubbing finding,
Yes, yes,
but before
yes.
he was healthy, there was no
Yeah.
problem growing.
He never get a hospitalization, or he never had lower respiratory infections.
That's very interesting.
Yeah. Therefore, we want to discuss him.
Yeah, and he's growing well, so yeah.
Yeah.
Okay.
And then we found the AV malformation.
Right.
Gamze, maybe you can continue.
Okay. Before and after treatment X-rays. This is before and after.
After embolization, yeah.
Yes.
And after that, he didn't have any complaint again.
That's very interesting.
Yeah.
Pulmonary arteriovenous malformations usually increase in size over time. In pediatric patients, this growth is relatively slow. Lesions double in size over about 5 years. It remains uncertain whether new arteriovenous malformations develop after birth or are initially too small to detect. Similar prevalence rates in children and adults suggest that most PAVMs are likely congenital. The size and number of lesions determine the clinical presentation of PAVMs. Small, isolated pulmonary arteriovenous malformations are often asymptomatic. These usually do not require treatment. In contrast, large or extensive PAVMs can cause symptoms. Diffuse PAVMs affect at least one lung segment. They are linked to an increased risk and embolic complications and a poor prognosis if surgical resection is not possible. Clinical features, PAVMs are usually asymptomatic but may present with a wide range of clinical manifestations. This includes cyanosis, dyspnea, exercise intolerance, digital clubbing, cardiac murmur, hemoptysis, and systemic embolism. Paradoxical embolism may occur leading to ischemic stroke, myocardial infarction, brain abscess, discitis, or migraine. PAVMs were first described in association with hereditary hemorrhagic telangiectasia, with approximately 70% occurring as a part of the syndrome, while the remaining cases develop sporadically. Pulmonary hemorrhage and hemoptysis due to rupture are uncommon in pediatric patients. Diagnosis diagram. Transthoracic contrast echocardiography, the similar name bubble echo, is highly sensitive for detecting PAVMs in both adults and children. The test involves intravenous injection of agitated saline, and the positive result is indicated by the appearance of bubbles in the left atrium shortly afterward. A negative study effectively rules out detectable AVMs at the time of testing. Consequently, transthoracic echocardiography is widely used as the initial screening tool. If positive, chest CT is performed to confirm the diagnosis and to assess the size and number of PAVMs. Although children with large or extensive PAVMs generally have lower oxygen saturation, supine versus upright oximetry provides low diagnostic yield and is not recommended as a screening method in pediatric hereditary hemorrhagic telangiectasia. And Management. Treatment decisions should align with patients' preferences and be made within a multidisciplinary team setting. Consider factors such as the patient's age, clinical symptoms, potential contraindications, and the effect size on radiological imaging. First-line therapy is embolization. In patients with PAVMs who present with low oxygen levels and exercise intolerance, treatment with transcatheter embolotherapy often leads to significant improvement or complete resolution of symptoms shortly after the procedure. Nevertheless, transcatheter embolotherapy is advised also for asymptomatic patients with larger PAVMs. And medical therapy may include oxygen supplementation, phlebotomy if hyperviscosity symptoms are present. Prophylactic antibiotics are recommended before dental, endoscopic, surgical, or other interventional procedures that may cause transient bacteremia. Iron supplementation in hypoxemic patients. And in patients with hereditary hemorrhagic telangiectasia and PAVMs with feeding arteries greater 3 millimeters, immediate embolotherapy significantly improves life expectancy and quality-adjusted survival. And transcatheter embolotherapy is safe in children with complications rates comparable to adults and no long-term adverse effects. The most common complication is pleuritic chest pain. Procedural issues such as device embolization or misplacement occur in about 3% of cases. Reperfusion occurs in approximately 15% of embolized PAVMs, warranting regular follow-up to detect recanalization, reperfusion, and progression of untreated small PAVMs. Complex PAVMs are technically more challenging and frequently require reembolization. To reduce septic embolic risk, good dental hygiene and prophylactic antibiotics before procedures with bacteremia risk are recommended. Inline filters should be used during IV infusions to prevent air embolism, and scuba diving should be avoided due to risk of gas embolism. And follow-up. There is no consensus on the optimal rescreening interval for pulmonary or brain AVMs. While most are detected at initial screening, some are identified only one repeat assessments. Since PAVMs enlarge over time, lesions too small for embolization initially may become treatable during follow-up. Pulmonary complications have been reported during pregnancy, warranting closer surveillance. At Sick Kids Hospital in Toronto, both children and adults with hereditary hemorrhagic telangiectasia are screened every 5 years, even in the absence of pulmonary AVMs. Evidence suggests this interval may be safely extended in both children and adults with negative initial screening. Asymptomatic children without AVMs are typically evaluated one clinically between screening visits. In cases of large multiple PAVMs or post-embolization, earlier reassessment is recommended to exclude recanalization or reperfusion. And pulmonary arteriovenous malformation must be kept in mind as a potential diagnosis in individuals presenting with pulmonary opacities accompanied by clubbing. Thank you
Perfect.
for your attention.
Good job. There is a question from one of the audience. The question is the clubbing in this case reversible?
No.
Okay.
No.
We did not have his genetic evaluation. Gamze, could you please show us the first PA and then BT screens?
Okay.
Maybe she gets so fast and maybe you didn't
Sorry.
realize it. Oh, yeah. there is a big AV malformation, and we got very good response to embolization.
That's all.
Okay.
Very impressive. Okay. Any other questions? Okay. Right.
We have one in the chat.
Oh,
Yeah, I just answered it. We didn't
Yeah.
have the genetic test.
yeah, and I answered the one that was sent to you. So yeah, so we're all good.
Okay.
All right. Well, thank you very much, and we can move on to the next case then.
No,
Great job, Gamze.
thank you.
Congratulations, Gamze. Thank you.
Thank you.
So this is another interesting case. It's beyond the ordinary rare cause of bronchiectasis. And Meltem, and I'm sorry, I'm butchering all the names. Meltem Kürtül Çakar. I don't know how. Yeah.
Yeah, great.
All right. Yeah, from another Ministry of Health, Ankara Bilkent City Hospital in Ankara. So.
Okay, I am start. Hello everyone, my name is Meltem. I am the final year of my fellowship in pediatric pulmonology at Ankara Bilkent City Hospital, Turkey. Today I will be presenting a rare case. He's an 11-year-old boy. The patient was first hospitalized at 3 days of life. He subsequently experienced recurrent pulmonary infection, which led to the development of bronchiectasis and eventually required BiPAP support. He was referred to our hospital at the age of 11 years for lung transplantation evolutions. He was born full term with no complication. There is a history of neonatal intensive care unit admission. Newborn screening test for cystic fibrosis was not performed, and routine vaccinations are up to date. Family history, parental consanguinity was present. The patient has 3 healthy siblings and no family history of respiratory disease. On physical examination, height and weight are below -2 SDS. Respiratory systems, pulmonary auscultations reveal diffuse crackles and rhonchus. Tachypnea was present. The anteroposterior diameter of the thoracic cage was increased, and digital being was noted. The patient was systemic examinations were normal. The laboratory results are shown here. They are nearly normal. Blood gas analysis PCO2 61. Chest X-ray, we can see diffuse bilateral infiltrates, right lower zone opacity and atelectasis on chest radiography. We can see thorax CT, peribronchovascular thickening and tubular bronchiectasis in both lungs, more prominent in the left lower lobe. In the distal regions, bronchiectasis was accompanied by a tree-in-bud appearance, marked volume loss in the right lower lobe with a large consolidation occupying most of this lobe. Hyperinflation of both upper lobes, ground glass opacities with perilobular distributions in the left upper lobe, accompanied by areas of septal thickening. Microbiological findings, sputum culture, Pseudomonas aeruginosa, and blood cultures was negative. Echocardiographic findings, secondary pulmonary hypertension, attributed to bronchiectasis and trivial mitral regurgitations. Abdominal uterus USG was normal, is normal. What is your most likely diagnosis? Pulmonary tuberculosis, immunodeficiency syndromes, primary ciliary dyskinesia, and cystic fibrosis. Evaluations for pulmonary tuberculosis. Clinical findings, no history of TB, fever, weight loss, severe or healthy. Gamma is negative.
Meltem, you're breaking.
CCR and culture negative. Radiological findings, thorax CT, but appearance. No cavitations or casting lymphadenopathy. Although bronchiectasis and tree-in-bud appearance, we were observed absence of exposure, negative microbiological IGRA and interferon gamma release assay, and clinical findings suggest that pulmonary tuberculosis was excluded. In the bronchoalveolar results, all findings were negative. The patients was evaluated for immunodeficiency. Chronic granulomatous disease was ruled out. Complement deficiency was not considered. T and B cell maturations was interpreted as normal in the lymphocyte subgroup analysis. Combined immunodeficiency was not considered in the patients with these findings. Evaluation for primary ciliary dyskinesia. The patients who was born term and had a history of hospitalizations in national and neonatal intensive care unit, history of recurrent otitis media and tympanic membrane perforation, but no history of congenital heart defects and recurrent visits. The Picader scores was 7. And NGS for PCD for 41 genes, no pathologic variants. The patients presented with severe bronchiectasis and recurrent lower respiratory tract infections and recurrent lower Pseudomonas aeruginosa in sputum culture, but Pseudobarter syndrome not present Sweet test 45 conductivity was normal. Stereotacrit in stool negative, but fecal elastase is down. CFTR sequence and MLPA analysis revelated no detectable mutation. Overall, despite clinical and microbiological findings supportive of cystic fibrosis, genetics and sweet test results did confirm the diagnosis. Wool exome sequence was sent for further genetics evaluations. And wool exome sequencing delivered as heterozygous variant in SCNN1A gene, which was presented as a variant of uncertain significance. The patient was considered to have an INAC mutation associated cystic fibrosis-like disease. INAC mutations, cystic fibrosis-like disease is SCNNA1A indicates epithelial sodium canals. Potassium and variation disrupt sodium transports, lead to intracellular fluid imbalance, impairs FTR receptors stabilization, results in cystic fibrosis, like signs and symptoms. In inheritance, polygenics, INACs variants and CFTR interactions, INAC activity up or down, clinical features, chronic bronchitis, bronchiectasis, sinusitis, Pseudomonas aeruginosa infections, and borderline to moderately high sweet chloride, rarely normal. And organ involved, primarily respiratory tract, sweat glands, less frequent pancreatic and gastrointestinal tracts, age of presentation, infancy, childhood, or young adult. Outcome variable depend or severity on pulmonary disease. Therapy no standard result regimen, and it's similarly to CF. Following 5 years longitudinal follow-up, lung transplantations was performed at the age of 16. Unfortunately, the patients died in the early post-operative period as a result of transplant-related complications. Thank you for your listening and
I have a
Thank you,
question.
Meltem. Well done.
Did you have one mutation? Is that what it is? Only one, not two?
Can I answer? He had only one mutation. It was a heterozygous mutation, and it was non-likely pathogenic. But we were shocked with the results because we thought that he had cystic fibrosis. We thought because he had normal or intermediate sweat tests, and his fecal elastase levels were low, and he had very large bronchiectasis everywhere, and he had severe clubbing and severe malnutrition. His CFTR genetic sequence were normal, MLPA was normal, and we were shocked with the results with whole exome sequencing. And he was in the variable group, polygenetic group. He was not with systemic disease in pseudohypoaldosteronism. He was in variable group. And after this results, we thought that this genetic results were pathogenic for him.
So the CFTR mutations, how many did you guys do?
We done all the sequence, next generation sequence, all the gen for CFTR gen. After that, NGS for primary ciliary dyskinesia, and after that, whole exome sequencing.
Okay. So where was the heterozygous mutation? Which chromosome was that on? Because you couldn't find anything in the chromosome number 7, right?
No.
Okay.
No,
So,
no.
okay. Do you know which
Absolutely not.
chromosome was this one?
I don't know.
For the
Sorry.
ENaC? Okay, that's fine. Thank you.
Sorry.
Meltem, do you have the picture of the VES result?
No.
Okay.
Yeah,
Yeah, that's a very unusual case, actually.
Thank you.
But great presentation. And yeah, good cases, you guys. You should write it up. So make sure to do that.
thank
Yes,
you.
Meltem wrote it, but it's in waiting in an original case.
Has
Thank
it
you,
been
Meltem.
reported to have people have disease when they have one normal allele and one abnormal? Has that been reported?
Yes, there's only one patient in the literature. We could only find one patient, and we decided to write this case, but we shouldn't finish it yet. Meltem is presenting it for years. After this patient, we had two patients with systemic pseudohypoaldosteronism with very severe disease, and they were presenting with severe electrolyte imbalance, not with this patient. This patient is unique, I think, because all the symptoms were and all the results were in intermediate. And if you look at this variable presentation, CF-like disease, ENaC mutation is only fit for this patient.
And did you guys do any other workup for the pancreatic insufficiency in this case?
Yes. He had gone pancreatic CT and MRs, and there was no anything about pancreatic insufficiency.
That's very interesting. All right.
Yes.
Any other questions?
Can you put the slide up again that shows the variant? I feel like the other ATS case that the fellows present on the second Wednesday, I feel like one of the centers had another patient that had this and maybe only had one variant, and there was a lot of discussion about it, but it could be I'm mixing it up. Yeah, the other slide. Yeah. Thanks. I just want to ask this other person if this was the same one or not. Thanks.
Thanks, Meltem.
Thank you.
Yeah, great job. Both of you did really a great job. Very interesting cases. So I don't see any other questions in the chat. Yeah.
And the baby presented so early, so now it's, another one of those things that can, it wasn't right at birth, but it was 3 days old, right? So that's really early.
Mm-hmm. Yeah, it's amazing to me that it's that severe. I mean, this, like CF-like syndrome, but it's so severe. That's very interesting.
Yes. We were shocked with the results.
Yeah. All right.
Is that channel involved at all with the, at birth with the, pumping the fluid out of the lungs or anything like that?
He had
forget.
a history for newborn intensive care unit hospitalization.
No.
Is 17
He
years.
had
And
yes.
our country, the screening test was 2025 to 20
15.
like 15, yes.
That's for the newborn screen, right? Is that what you're saying?
Yes.
Yeah.
Yeah.
Thank you.
That's very interesting. I guess you learn every time, there is cases like that. You're like, whoa, wait a minute. I thought the Enoch channel is not really, cannot cause that much damage. And I thought it was a negative channel rather than an active channel like the chloride channel. But again, I'm amazed that this is something that's happening and it's causing that much damage. I have no patient like that. So that's very interesting.
In my fellowship, we always talk about ENaC mutation, but I didn't see any patient like that.
Mm-hmm. Yeah. Right. Okay, I think we're done. If there's no other questions, Ozgi, that you want to finish it?
Yes, I think there are no other questions, but both cases were very interesting. Thanks, Samya, for chairing the session, and we thank Dilber and her team for preparing the case presentations.